Right, thanks very much for the introduction. Thanks very much for the invitation to be here today. It's my pleasure and it's my honor. Again, I have to apologize because I need to cram a lot of information in a very short time, so probably you're going to see a lot more slides than what you actually should, but if you need any more details, I'm more than happy to discuss all the information in my poster. Well, I have to say this is the group of pathologists from the Granada hospitals that have transitioned from the microscope into the uncharted waters and the frightening world of digital pathology for primary diagnosis. And basically, the microscope was left behind 2.5 years ago, actually, and so far we're doing quite well, actually. None of us have gone to jail, our patients are doing great, and overall it's a happier bunch of pathologists practicing the profession. I have to say that I'm born and bred in Granada, did my training there, was involved in the transition, subsequently became a consultant for Philips digital and computational pathology, so that's my interest. A little bit about Granada. The total population area is about 1 million inhabitants, and the Granada Hospital service provision is composed of 4 different centres, 2 teaching hospitals that cover the metropolitan area, and 2 peripheral hospitals in the towns of Motril and Baza. As I said, overall 23 pathologists, and we do follow a rota to cover the different sites, to do the cut-ups, to do the frozen sections, etc., etc. So in a nutshell, that's who we are. And as I said earlier, what makes Granada pathologists different, what makes them special, is the fact that basically we left the microscope behind 2.5 years ago, and we've been doing all primary diagnosis on digital basis. And this is the heartbeat of the digital pathology system. It's actually a scanner that does 32 slides per hour on average, that is prepared for unsupervised scanning, which is essential if you want to do primary diagnosis. That scans at 40x, and we believe that that is basically what you need for primary diagnosis. There is a number of cases, of course, that you could diagnose safely at 20x, but in our experience, you really need to have the extra additional detail that digitizing at 40x provides. Obviously, the system is integrated with the laboratory information system, which in our case is Vitropath, is a local Spanish company. And the error rate, nobody likes to talk about errors, but I think it's essential. The error rate is actually quite low, but we had to do some fine-tuning, especially in the pre-analytic phase, to allow for this low error rate. If you require any more details, I'll be very happy to discuss the poster later on. Memory is very important, and the reason for that is that each glass slide that you digitize actually weighs about 1.2 to 1.5 gigabytes. So what do you do with all of this information? Well, we heard the words big data in a number of occasions, and that's what we believe that we should do, actually. If we erase the data, we're not creating big data by definition. So we need to store all of this information. And this is the kind of setup that we have at the moment. We have memory in 2 tiers. First tier is live memory, which basically lasts for about 1 year. So we've got online images pertaining to the last 12 months in that year. And everything older than that goes to the long-term storage, which has capacity for about 1 petabyte. Again, 64,000 cases a year. We scan everything and we diagnose everything on digital. An overview of the solution design architecture. The key element here that I'd like to draw your attention to is the portal server, because what the portal does is communicate the different servers of the different centers. And this is basically what enables the fact that all the glass slides are available to any of the pathologists across the network at any particular time. And this obviously has a series of advantages, like the fact that you can assign cases to pathologists according to subspecialty interest and not necessarily according to geographics. So in other words, you can shift the caseload quite efficiently across the network in a much more efficient way than what it would be involving shipping glass slides, paraffin blocks, etc., etc. In our experience, it's inevitable to question ourselves whether it was worth it, basically. So a lot of very commonly mentioned concern is the fact that digital pathology may actually slow you down. But in our experience, what we did was actually look at the numbers in terms of efficiency to see how many cases per pathologist we sign out on a year-to-year basis, and compare that to what it was when we were on the microscope. And that was 2015. That was the last year we were fully on the microscope. So basically what we see is 2 things. One is declining number of pathologists due to retirement. And the other thing that we see is increasing number of caseloads. basically because we're part of the public Andalusian health system, because we got obviously screening programs, because clinicians do more and more tests, etc. By those for those reasons, the number of the caseload actually keeps increasing. So we got two things: decreasing number of pathologies, increasing number of samples. And actually, if you do the numbers, we can see what each of the pathologists sign out on any given year. The trend that we see is that the first year we did an increase of 15% more cases per pathologist. The following year, that number was 20%, and the following year was 26%. So in other words, if you average it out, you get an average of 20% more cases per pathologist since we implemented digital pathology. There might be some other confounding factors, of course, but we have reasons to believe that digital pathology was had a significant impact in facilitating this ability to absorb more cases with less pathologists. Actually, if you do more number crunching, you can see that the delta between that number and that number is 11,000 cases. So at the rate that we were signing out cases back then, right, we would have needed between 5 and 6 more pathologists to absorb that additional caseload that we simply don't have. Okay, so in a nutshell, that is our experience with having gone digital at Granada hospitals. Again, apologies for the lot of information in a very compressed time, but just to say that we got some microscope for sales in Granada, just in case you're interested. I'm very happy to take any questions. Thank you very much.
Thank you. Very impressive questions.
Just about the efficiency, your pathologists are more efficient than they were before. Do they feel like they're more efficient? Do they feel like they're working harder? Can you tell us why?
Yes, we actually did a survey, but unfortunately time did not permit to add all of this data. And overall, they feel that they've gained 1 extra day a week by going digital. So that was the subjective opinion, and that was basically what motivated us crunching the numbers to see whether there was indeed that kind of correlation. So we did ask our pathologists. The bottom line, the last question in the survey was, after having tried digital pathology, would you like to go back to the microscope? 100% of them say, no way. So we must have done something right, which is probably surprising for Southern Spain, but there you are.
Another question?
Thank you very much. I just wanted to ask you about cytology. Did you digitize all the cytology material as well?
No, bear in mind that this system is actually licensed just for formalin fixed paraffin embedded tissue. It's not licensed for cytology. Okay. Having said that, we do scan smears in sentinel lymph node, and for filing purposes. And obviously, we do look at those images, not for diagnostic purposes, but just to corroborate and to double check. The results are acceptable in a quite high number of percentage of cases, but it's not fit for primary diagnostic purposes, basically.
Thank you.
If I may have a question about the archiving. So you're planning to store your 40x magnification images, and you also plan to store your slides. What is your policy on that?
Yes, for the time being, we store everything, the digital images and the glass slides. It's probably one of those classical examples in which regulation, it's not as quick as technology. So at some point, obviously, regulation will catch up and will tell us what to do with the glass slides. But for the time being, obviously, we need to keep everything.